Good morning. Today we'll be talking of vaginal bleeding in early pregnancy. Now all of us know that a term pregnancy or a full term pregnancy is from 37 to 40 weeks, and we calculate the expected due date from 9 months 7 days from the last menstrual period. That means the total pregnancy duration is about 40 weeks. So if we talk of vaginal bleeding in early pregnancy, we usually mean any bleeding occurring in the first 20 weeks of pregnancy. The session objectives for our class today is to be able to diagnose the cause of bleeding in early pregnancy and appropriately manage this condition and refer to the higher center if required, if facilities are not available in your place. So definition we've already done: bleeding that occurs during the first 20 weeks of pregnancy. Now why could it be? It could be an abortion. That means the patient may be threatening to lose her pregnancy. It could be an ectopic pregnancy, a molar pregnancy or vesicular mole. It could be an implantation hemorrhage, or it could be bleeding from the cervix or the mouth of the uterus. By definition, any bleeding that occurs in the first half of pregnancy or early pregnancy is not included in antepartum hemorrhage. When we use the term antepartum hemorrhage, it usually refers to bleeding that occurs after 20 weeks. Now let us take these one by one. First is abortion. What do you mean by abortion? So termination of pregnancy, either spontaneous, means by itself, or induced, like it is medical termination of pregnancy before 20 weeks of gestation. Abortion could further be classified into threatened, inevitable, incomplete, missed, complete, and septic. What do we mean by these? Threatened abortion means that there is light bleeding, there is abdominal pain, but the cervix or the uterine mouth is closed, and if you see the size of the uterus, it is appropriate for gestation. Inevitable abortion: there is more bleeding, there is pain, the cervix is open, but the fetus has not been expelled or the products of conception are still inside the uterus. This abortion is known as inevitable. The third is incomplete abortion. Here there will be more bleeding, there will be pain, there will be the presence of uterine contractions and expulsion of the products of conception from the uterus into the cervix and vagina. The os will be open. In missed abortion, the patient may complain of light bleeding with abdominal pain. When you examine her, the size of the uterus will be less than the period of gestation, and there will be no fetal heart sounds. If you do an ultrasound in a patient with missed abortion, you will be able to confirm the absence of fetal heart, absence of any fetal movement, and the fact that the gestational sac becomes irregular with areas, maybe areas of subchorionic hemorrhage. An unsafe abortion usually follows an induced abortion. There is bleeding, there is trauma to the vagina or the cervix, and there is the presence of foreign bodies with signs of infection. How do you diagnose what sort of abortion it is? By taking a proper history, establishing the duration of pregnancy, doing a clinical examination to find out whether the size of the uterus corresponds to her duration of pregnancy. If you have a doptone, you should be able to pick up the fetal heart by about 12 weeks of gestation and by doing a pregnancy test. Ultrasound is useful for confirming a failed pregnancy and or the presence of retained products of conception. Among the differential diagnoses that should come to your mind is ectopic pregnancy. If you compare ectopic pregnancy to abortion, there is more bleeding in abortion and pain is not so severe. In ectopic pregnancy, especially if the tube has ruptured, pain is severe, bleeding is slight, and if it's a ruptured ectopic pregnancy, her general condition may not be stable. She will have low blood pressure with a very rapid pulse. We will be talking of ectopic later in our presentation. Cervicitis, yes, sometimes cervicitis, especially due to gonococci or chlamydia, may give rise to bleeding from the cervix. But if you put a speculum, you will be able to see that the blood is coming from the cervix itself and not from inside the uterus. Then it could be ectropion, which tend to sometimes bleed, a cervical polyp, or it could be a functional uterine bleeding also. What is the management of bleeding in early pregnancy? This is in general, not only for abortion, but for any bleeding that occurs in early pregnancy. The first thing, you should be able to evaluate the woman's condition, see her pulse, her blood pressure. If there has been a lot of bleeding, she may be in shock. In such a situation, you should begin the resuscitation. If bleeding is less but shock is out of proportion, consider ruptured ectopic pregnancy. Infuse IV fluids, administer oxygen. If she has not had a vaccination or her vaccination history is uncertain, here is the time when you can give her a tetanus toxoid. Do urine examination, hemoglobin, and do her blood group and type. If required, cross-match and keep blood ready. Give antibiotics and consider for evacuation if you feel that this is incomplete or inevitable abortion. For pain, you can give her tramadol. Let us talk of management of threatened abortion here. Threatened abortion, we will recollect again, is when the uterine size is appropriate for gestation. That means if she gives you a history that she is about 3 months pregnant, you examine her, the uterine size is about 12 weeks, that means just at the level of the symphysis pubis. You are able to auscultate the fetal heart with the help of your Doptone, or you get an ultrasound done and the cardiac activity is there is minimal bleeding. In such a case, you may advise the woman to take some progesterone supplement like micronized progesterone 200 milligrams twice daily or dydrogesterone 10 milligrams twice daily. You should also advise the woman to avoid strenuous activity and sexual intercourse. Complete bed rest is not necessary. You tell her to limit her activity. Either the threat of the abortion would recede, that means it would go away, or the abortion would become inevitable. That means the os would start opening and bleeding would increase. If the bleeding has stopped, then you just follow her up in the antenatal clinic. If bleeding persists, get an ultrasound done, check for fetal viability, or check if it is a possible ectopic pregnancy. Persistent bleeding, particularly in the presence of uterus larger than expected, may indicate twins or molar pregnancy. This would be confirmed on an ultrasound. What about how to deal with an inevitable or incomplete abortion? Inevitable abortion is When the size is appropriate but bleeding is more and the os has started to open, the process of abortion has already started. And we term it as incomplete if parts of the products of conception, that means either the fetus or some part of the placenta has come out and the rest of it is still inside the uterus. Bleeding at such a time is usually more. Okay, so this is how you differentiate inevitable and incomplete abortion from threatened abortion, where we should be as conservative as possible, and inevitable or incomplete abortion where we need to be more we need to go forward with the evacuation. So general measures: you check her pulse rate, her blood pressure, check her temperature, assess the severity of bleeding. In the event of heavy bleeding, you must ensure that you get an IV line in with a 16 or 18 gauge cannula. Give a ringer lactate. You may add 10 to 15 units of pitocin into the ringer lactate to help the uterus to contract and the parts or products of conception to be expelled more easily. Monitor the heart rate, blood pressure and bleeding. Prepare for a possible transfusion. Give analgesics. Remove any products of conception in the cervix and vagina digitally with your fingers, and then take the patient in for a uterine evacuation. Uterine evacuation can be done with your MVA or manual vacuum aspirator, or it could be done with the electric suction machine, that is known as suction and evacuation. If you don't have an MVA, you don't have a suction evacuation, then maybe an instrumental removal with ovum forceps followed by a gentle curettage, which is also known as instrumental curettage, may also be done. But the preferred and the safer method is to use a MVA or a suction evacuation. Especially if the uterus is 12 weeks or less, it is easy to evacuate it. Keep a pitocin drip, as I said, running and remove with your MVA. However, if the pregnancy is greater than 12 weeks, you may need to give her oxytocin till the fetus is expelled. Again, oxytocin is given in saline. 20 units can be used. Or if you don't have oxytocin and you don't want to give it an IV fluid, you can give her tablet misoprostol for 2 tablets or 400 micrograms 4 hourly till the fetus is expelled. The placenta usually needs to be removed either with the ovum forceps or with your suction. Ensure follow-up after treatment, where you may help her with her contraceptive decisions also. After 16 weeks of pregnancy, that means if the uterus is more than 16 weeks of pregnancy, the fetus usually gets expelled, but the placenta may be retained. If it doesn't deliver normally within a couple of hours, you need to start an oxytocin drip, again 20 units in 540 ml of saline or ringer lactate. Wait for 2 hours, otherwise perform an evacuation, which can be done with either suction or with your ovum forceps. In rare cases, even after expulsion of the placenta, patient may continue to bleed. Such patients need to be referred to higher facility after stabilization. That means after you've gotten an IV line, you've given her blood, or at least arrange for the donors and made sure that when you refer the patient, you shift the donors along with the patient and a duly filled referral form. Ensure post-abortion follow-up of the woman after 2 weeks. Here, one thing is that you can look out for any infection, any sepsis that she may have developed, any other problems, any continuous bleeding which may point towards retained placental pieces or retained products of conception. And if nothing is there, then you can tell her about contraception. You can advise either oral contraceptive pills, or after her next period she can come in for a copper T insertion. We go on to missed abortion. Now, missed abortion is when she has slight bleeding, you examine her, the uterine size does not correspond to gestation. She is telling you that she is 4 months pregnant, but the uterine size is not only 12 weeks. You get an ultrasound done and you find out that there is no fetal cardiac activity, there is no fetal movement, the gestation sac has become irregular, and there may be evidence of subchorionic bleeds. These patients require to have a coagulation profile done, or at least a bleeding time, clotting time, because they are prone to bleeding abnormalities. If the size is less than 12 weeks, then you can do the uterine evacuation either with the manual vacuum aspirator, or you can do it by the help of medicines. That means you give misoprostol 3 tablets sublingually every 3 to 4 hours. Once the fetus is and placenta is expelled, you can stop, or if you have given up to 5 doses, then you need to stop and consider adding in another means. That means if misoprostol does not work and you've given 5 doses, you need to do a manual aspiration either with the MVA or with the suction, electric suction. Supposing the patient is between 13 to 22 weeks, then you need to give her misoprostol. This has to be given as 2 tablets every 4 hourly. You can repeat up to a maximum of 5 doses. Usually patients respond and the fetus gets expelled in this time. If it hasn't occurred, the os is sufficiently dilated for you to remove with the help of a MVA or with the electrical suction. If the patient has got uterine scars, or she is a grand multi, or there is over distension of uterus, you need to be a little cautious when you give the misoprostol, as fewer numbers of doses would be required. There is a possibility that misoprostol could cause very bad contractions and the patient could have a rupture. So you need to half the dose of misoprostol if the patient has got uterine scar, if she is grand multi, or there is an over distension of the uterus. What about a complete abortion? If you are sure that all the products of conception, the fetus, the placenta, the membranes have been expelled, there is no more bleeding, then you don't need to do anything other than reassure the woman and call her for follow-up after 2 weeks. What about septic abortion? Though usually when we talk of septic abortion, it follows an induced abortion, but sometimes even spontaneous abortion, if the products of conception have not been completely expelled, and you all know that the blood is a very good culture media, then the infection starts and the patient presents with fever, abdominal pain, a tender uterus with foul smelling discharge. If you're suspecting that it was induced with some illegal means and there is the presence of any foreign bodies in the vagina and cervix, remove them. Administer antibiotics. Now the antibiotics that are recommended are amoxicillin clavulanic acid plus gentamicin, or ampicillin metronidazole plus gentamicin in the doses that we usually give. That is ampicillin 2 grams every 8 hourly, metronidazole 500 mg every 8 hourly, gentamicin 5 mg per kg body weight once daily. Once you've given the antibiotic, you can proceed with your evacuation, because the patient will only respond once the uterus is empty. As long as the products of conception, especially infected, are lying in her uterus, she will not improve in her general condition. So you need to remove the products of conception. So once the antibiotics are within 12 to 24 hours, you should take the patient for evacuation. This can be done again by manual vacuum aspirator or with the electrical suction machine, that is known as suction evacuation. Continue IV antibiotics till there is no fever for 48 hours. Then you can change to oral antibiotics, again using either amoxicillin clavuanic acid 3 times a day for 5 days or ampicillin metronidazole for 5 days orally. For very severe infection where there is a perforated uterus or evidence of peritonitis, you may continue to treat the patient for 10 days. Also find out about her tetanus immunization. If she has not been immunized, give her a dose of tetanus toxide along with tetanus immunoglobulin also for immediate effect. What is the follow-up that you need to do after abortion? Tell the woman that spontaneous abortion is common. Reassure her that chances for subsequent successful pregnancy are good unless there has been sepsis or a cause of abortion is identified that may have an adverse effect on future pregnancy. That is very rare. Advise her to delay her next pregnancy by at least 6 months. Provide counseling for women who've had an unsafe or an illegal abortion. If pregnancy is not desired, start a contraceptive method immediately after appropriate counseling if there is no severe complication requiring further treatment. So we summarize that vaginal bleeding in early pregnancy has wide differential diagnosis. It could be abortion, it could be ectopics, it could be molar pregnancy. Diagnosis can often be made clinically, saving time and expense. Now we will talk a little on ectopic pregnancy, which will be detailed in further lectures. So I'll be very short over here. Now what do we mean by ectopic pregnancy? It is the implantation of a fertilized egg outside of the uterine cavity. Now this is usually in the fallopian tube, because all of you all know fallopian tube is where the fertilization occurs, and after fertilization the fertilized ovum or the blastocyst travels to the uterus. If some certain problems hinder the pathway of the fertilized ovum or the blastocyst, you may have an ectopic pregnancy. So ectopic pregnancies are common where there is a history of peritonitis or a history of pelvic infections or even sometimes endometriosis. The most common site, as you can see, is the fallopian tube. In 95% it is the fallopian tube, and in the fallopian tube the most common place is the ampulla or the ampullary pregnancy. Ovaries are involved in 2%. Abdominal pregnancies, especially secondary abdominal, is seen in 1%. Cornual pregnancies occur in 2 to 6%, and cervical pregnancies are the rarest. What are the symptoms of an unruptured ectopic pregnancy? Symptoms of early pregnancy would be there, that is amenorrhea, nausea, swelling of the breast, bluish discoloration of the vagina and the cervix, a soft cervix, slight uterine enlargement, and increased urinary frequency. These are all the symptoms of early pregnancy. Along with that, the patient may complain of abdominal pain or pain on one side of the abdomen. There could be irregular spotting or bleeding, and when you examine the patient, there could be abdominal tenderness, often unilateral. There would be guarding on that side. Possible when you do an internal examination is to find an adnexal mass, and very significant is tenderness on cervical movement and posterior fornix tenderness. If the ectopic has ruptured and the patient is bleeding into the peritoneal cavity, she may present in a very acute state. There could be collapse, there could be a fast, weak pulse, there could be fall in blood pressure, she could show all signs of hypovolumic shock, acute abdominal and pelvic pain, abdominal distension because of the blood collection and also because of the starting of peritonitis, rebound tenderness and increasing pallor. A cervical pregnancy is very rare. It most commonly resembles an incomplete abortion. It is often discovered due to massive bleeding during manual vacuum aspiration or curettage to evacuate the uterus. Pregnancy test would be positive, usually. Very rarely it may become negative. Ultrasound shows an empty uterus and in some cases an adnexal mass and fluid and blood in the abdominal cavity. If ultrasound is unavailable and there is still some doubt, you can do a caldosynthesis. Caldosynthesis is aspiration from the pouch of Douglas. If altered blood comes out, we know there is hemoperitoneum and this patient has most probably got a ruptured ectopic. The procedure is pointless, that is caldosynthesis need not be done if you've got a good ultrasound which shows a ruptured ectopic and you're going to plan a laparotomy anyway. Differential diagnosis that come to mind is threatened abortion, acute or chronic PID, ovarian cyst, torsion or rupture, acute appendicitis or diverticulitis. When a hematocele is present or suspected, you could also consider pyosulfings, fibromas and pelvic abscesses. When hemoperitoneum is suspected, consider gastric or duodenal perforation or ovarian cyst rupture in your differential diagnosis. What is the management? If the patient is stable and you are thinking this is an unruptured ectopic gestation, you have facilities of ultrasound, it is an unruptured ectopic, you have time, refer her to the district hospital or to the medical college hospital. If it's a ruptured ectopic, then this sort of patient should preferably be managed in your own center where you've seen her, manage her shock, stabilize the patient, insert an IV line, 16 to 18 gauge cannula, administer ringer lactate, monitor her vitals, her heart rate, her blood pressure, the amount of bleeding, arrange for a possible transfusion, and if you have the facilities, do an emergency laparotomy and remove the tube that has ruptured, that is known as self-injectomy. Some special cases, if you are in a peripheral center and you have encountered a cervical pregnancy, you can temporarily stop the bleeding by inserting a Foley's catheter into the cervix and inflating it, or by tying a tight circlage round the cervix. If you've encountered an abdominal pregnancy, this also requires a laparotomy. Depending on its location, removing the placenta may be difficult. In that case, you can leave the placenta in situ, clamp the cord as near the placental insertion as possible, and the placenta will then degenerate and be absorbed by autolysis. Next we come to molar pregnancy, or what is also known as hydatiform mole or vesicular mole. It's a pathological pregnancy due to the cystic degeneration of the placenta. There is abnormal proliferation of the chorionic villi. The mole presents in the form of translucent vesicles, 1 to 2 centimeter in diameter, connected by filaments. They look like a cluster of grapes. In most cases, there is no fetus and no amniotic sac. The symptoms and signs of vesicular mole: there would be spontaneous bleeding of variable severity. The uterus is usually larger and softer than the expected for gestational age. There will be no fetal parts, no fetal movements, and no fetal heart. These signs of pregnancy are usually exaggerated, that means they are more. You may have more nausea, more vomiting. This is because of the very high levels of human chorionic gonadotrophin. You may have occasionally edema, proteinuria, and hypertension. Sometimes, because of the increased chorionic gonadotrophins, you may have enlarged ovaries. There could be weight loss, mild jaundice, and sometimes the patient may present to you with the process of expulsion of the mole already taking place. She may come with the history of passage of vesicles and more severe bleeding. The pregnancy test is usually positive. Ultrasound shows a heterogeneous vesicular placenta which fills the uterine cavity. Management: if the patient is not bleeding, there is time, you can refer to the higher center, because there is always a risk of bleeding, and this uterine evacuation in molar pregnancies sometimes becomes a little complicated. So if possible and the patient is stable, refer her to the higher center. If diagnosis is certain, patient is bleeding, you need to evacuate the uterus. Again, insert a large bore cannula 16 to 18 gauze, start an IV line, administer ringer lactate. To the ringer lactate, you can add 15 to 20 units of oxytocin. Monitor the patient's heart rate, blood pressure, and bleeding, and prepare for a possible transfusion. The mole can be usually evacuated if you've got multiple manual vacuum aspirators. Keep 2 loaded or 3 loaded, or if you've got an electric suction machine, the mole can be removed by suction evacuation. Once you finish this procedure, you need to do follow-up. Follow-up is done by measuring the beta HCG levels immediately after evacuation, then weekly till she reaches normal levels, after which you may measure monthly into 6 months. Why are we doing this? Because there is always a risk that 10 to 15% patients with vesicular mole may develop persistent trophoblastic disease or choriocarcinoma. Such patients should be referred to the district hospital or the medical college for further workup. 2 weeks after evacuation, perform an ultrasound to be sure that the uterus is empty. If ultrasound is not available and bleeding persists, consider doing a second MVA or a suction evacuation. Monitoring is usually done nowadays with beta HCG levels, which should become negative within 8 weeks. Once the beta HCG levels have normalized, you can give the patient hormonal contraceptives and ask her to prevent pregnancy for at least 1 year after a vesicular mole. If the patient has completed a family, you can offer her voluntary tubal ligation. If beta HCG levels or the urine pregnancy test is negative, you need to repeat the levels once a month for the next 6 months. Not for a year as well, once a month for the next 6 months. If they test positive after 8 weeks or become positive during a subsequent follow-up, refer the patient to rule out or treat persistent trophoblastic disease or choriocarcinoma, provided you can rule out pregnancy also. Now, certain 2 more causes I will be telling you other than abortion, vesicular mole and an ectopic, which may cause bleeding in the early weeks of pregnancy or before 20 weeks of pregnancy. And one that we miss out is cervicitis. Inflammation of the cervix caused by chlamydia or with Neisseria gonorrhoeae would cause light vaginal bleeding, a cervix on per speculum examination which is red, inflamed and infected. There could be concomitant vaginitis also. The management would be to administer antibiotics which are active against chlamydia and gonococcus to the patient and her partner. You may also offer her a pap smear and follow up the patient after 3 months to re-examine her cervix. Another cause of light bleeding in early weeks of pregnancy is implantation hemorrhage, which is quite common. Bleeding is usually very light. It occurs round about the expected menses, that is about 10 to 14 days after conception. The uterus is normal size, though may be soft. There is a long, closed, soft cervix with no adnexal mass, no cervical movement tenderness. The pregnancy test is positive. Now, this is something that occurs in some pregnancies, and the outcome of the pregnancy is usually normal. So what the management is that you just reassure the patient, no medication is important, tell her this is implantation hemorrhage. At the most, tell her to have a little rest and avoid sex and report back to you if it reoccurs. Usually it does not. It is very light bleeding. So this is implantation hemorrhage. To sum up, bleeding in early weeks of gestation may be implantation hemorrhage, may be due to local cervical cause, and may be a abortion, an ectopic pregnancy, or a molar pregnancy. What you need to do is a proper history taking, establish the duration of pregnancy, check the general condition of the patient, then do an internal examination to find out whether the size of the uterus corresponds to the duration of pregnancy. If she is round about 3rd month or 3 months complete and you have a Doptone, you should be able to pick up the fetal heart sounds with your Doptone. If you don't have Doptone facilities but have an ultrasound, check for fetal viability. If the fetal viability is there, patient has not bled much, then you should be conservative if the pregnancy is an threatened abortion. If the fetal cardiac activity cannot be documented and you suspect that it's a missed abortion or an incomplete abortion, then you need to be a bit more, you need to go in for an evacuation. If you can't see a pregnancy sac in the uterus and the pregnancy test is positive, look at the adnexal region and see whether it's an ectopic pregnancy. If you cannot see any adnexal mass or an ectopic pregnancy, ask her to come back to you in 3 to 5 days. If it is a molar pregnancy that is seen, then patient is not bleeding, patient is stable, you should refer such patients to a higher center. However, if it's a molar pregnancy with a bleeding patient, stabilize her and do the evacuation there only and tell her about follow-up. Thank you so much.